Welcome, everybody. This is another Musella Foundation Brain Tumor webinar. Today's topic is assessment of treatment response to established and novel therapies in glioblastoma patients using metabolic and physiologic MR imaging techniques by Dr. Sanjeev Chawla. Go ahead, Dr. Chawla.
Okay. Thank you, Dr. Musella, for giving me an opportunity to present our work. And I would like to thank and welcome everyone who is attending this webinar. And I would also welcome questions at the end of this talk, and I will try to answer as many questions as possible. And anyone can also reach me through email for further clarifications. So as Dr. Musella mentioned, that the title of my talk is Assessment of Treatment Response to Established and Novel Therapies in Glioblastoma Patients using Metabolic and Physiologic Imaging. So essentially, my talk is basically divided into two different components. In the first component, I will talk briefly about the general characteristics of the glioblastomas, and then the evaluation of the treatment response to standard of care therapies. And in the part two, I will mainly focus on the advanced novel modalities to treat GBMs like tumor treating field and immunotherapy. Just for the sake of in the interest of the time, I will touch upon only chimeric antigen T cell receptor therapy. So to begin with, so what is glioblastoma basically? So as we all know that glioblastoma is a deadly brain cancer, and it's the most common aggressive brain neoplasm in the adults, and it comprises approximately 30% of the all central nervous system tumors. And in US every year, approximately 14,000 new cases arise. And the incident rate is approximately 3.19 per 1 lakh persons per year. And the incidence of the GBM is highest in the age group of 45 to 65 years, which is a prime age of life. And these GBMs are highly heterogeneous in nature. As you can see, this is the post-contrast T1-weighted image showing a glioblastoma in the left temporal lobe. And it is highly heterogeneous. As you can see there, this is the solid contrast enhancing region. This is central necrotic core. This is a contrast enhancing rim, and this is vasogenic edema. And the GBMs are also highly infiltrative, like the tumor cells and the neoplastic cells, they can infiltrate in the normal brain regions several millimeters beyond the contrast enhancing region, along the white matter tracts or the blood vessels. And these are the regions where the tumor recurrence usually occurs. And this is one of the major reasons why the clinical outcomes of patients with the GBM is poor, because of this tumor recurrence, which inevitably takes place in those particular infiltrative tumor components. And on the normal conventional imaging or the histopathology, there is no discrete boundaries which can separate from the solid component of the tumor from the infiltrative tumor components. So it's very hard to differentiate these two components based on the conventional neuroimaging or even on the histopathological specimens. So the standard of care for the treatment of GBMs includes surgery and the chemoradiation therapy. And the novel modalities includes electrical field therapies, which are also called tumor treating field, immunotherapies, and targeted therapy. There are various targeted therapies available these days. So what is the impact of standard of care therapies on the overall survival of patients with GBMs? So when these patients are not treated with any treatment modality, when they are not treated with any treatment modality, then the overall survival of this patient is less than 3 months from the date of diagnosis. When the patients are treated with surgery and radiation, the overall survival is approximately 12 months. So when they are treated with surgery, radiation, and chemotherapy in the form of temozolomide, which is an alkylating agent, then the overall survival is approximately in the range of 14 to 16 months. So as you can see, this is the outcome of this patient is very, very poor, and the 5-year survival rate is less than 5%. So after the end of chemoradiation therapy and surgery, what happens? Like in approximately 80% of these cases, a new lesion develops at or near the surgical cavity within 6 months after the end of the chemoradiation therapy. So as you can see, this is a post-contrast T1-weighted image. As you can see, this is the tumor in the right parietal lobe. This is a pre-surgical time point. And this image shows this particular GBM case 1 day post-surgery. As you can see, this is the surgical cavity, and there are very little or no evidence of any tumor cells. But within 3 months after the end of the surgery and the chemoradiation therapy, you can see this is the lesion. There's a contrast announcement at or near the surgical cavity. So what this new lesion represents? So this new lesion may represent tumor progression, which is the real tumor, or it may also represent pseudo progression or the false tumor. So why there is a tumor progression or the PSP? PSP mainly is mediated by temozolomide, which induces the increased vascular permeability and profound inflammatory reaction or the inflammatory reaction within the tumor bed. And the phenomena of PSP is generally transient, spontaneously it stabilizes or stabilizes without any further treatment. So patient with the TMG or patient with the PSP, actually they are more responsive to the TMG treatment, and they have better clinical outcome, and they have prolonged overall survival. And most of the time, these patients are simply monitored with short interval follow-up MRI scans. On the other hand, patient with TP, they may undergo repeat surgery, or they may also be subjected to alternative therapy, such as electric field therapy, immunotherapy, or Avastin, which is essentially an anti-vascular therapy. So that's why it is very important to distinguish TP and PSP to design a particular treatment modality for a particular patient. So what are the how do we determine what is the final diagnosis? How can we make the final diagnosis whether this particular lesion is TP or PSP? So in some patient, the patient who undergo repeat surgery, then we have a tumor specimens, and then by using the histopathologic analysis, we can determine whether the particular tissue is TP or PSP. If the malignant features are more than 25%, then this particular tissue specimen is considered as TP. If the malignant features are less than 25%, then the particular tumor specimen may be considered as PSP. But in most of the times, patients don't undergo any repeat surgery. So in that case, what we do basically, we use conventional diagnostic MRI scans, especially the 2 consecutive follow-up diagnostic MRI scans, and then we use updated response assessment in neuro-oncology criteria to determine the final diagnosis, whether a particular lesion is TP or PSP. So how do we do that? So first of all, we determine the tumor size. So tumor size can be determined by looking at the tumor volume, or we can determine the SPD, which stands for the sum of product diameters. So as you can see here, this is the post-contrast inverted image. This is after the surgery and the chemoradiation therapy. So this, as you can see, this is a large surgical cavity, and this is the contrast enhancing region, and these are the 2 cross-sectional diameter. As you can see, these are 2 cross-sectional diameter on the largest on the slice, which show the largest lesion. So we basically then take we multiply it, and then we take the sum of these 2 bidimensional measurements, and then we take 2 imaging time points in an interval of approximately 4 to 6 weeks to determine the outcome. And then what is the response? Like how do we determine the response based on the updated RANO criteria? So if there's 100% decrease in the tumor volume, or there's 100% decrease in the SPD, means like there is no evidence of any tumor within the after the end of the chemoradiation therapy, or like there is no evidence of any tumor, then we may consider this particular patient or particular tumor as a complete response. If there is a more than 65% decrease in the tumor volume, or more than 50% decrease in the SPD, then that particular lesion may be considered with the partial response. If there is a more than 40% increase in the tumor volume, or there is a 25% increase in the SPD, then that particular lesion may be considered as progressive disease or tumor progression. If a particular lesion is associated with more than 65% decrease or 40% increase in the tumor volume, or 50% decrease in the SPD, or 25% increase in the SPD, then those particular lesions may be considered as stable disease. Okay, but there are some limitations associated with the conventional imaging. So like the updated RANO criteria is not highly reliable. So there are some like pitfalls and limitations. So as you can see here, these are the, I'm showing you there are 2 cases here, and the upper row, you can see these are the post-contrast tumor-weighted image, and the bottom row, you can see the T2-FLAIR images. So as you can see on the post-contrast T1-weighted image, the lesion size is approximately similar, and both of them are showing enhancement, and in the form of a ring enhancement. And on the T2-FLAIR images, you can see there is a profound vasogenic edema. So both of these cases are showing similar pattern of the contrast enhancement and similar extent of vasogenic edema on the T2-FLAIR images. So it's very hard to differentiate which case is which, whether this case is TP or PSP or this case is TP or PSP. So this is another example. So as you can see, this is the case of the pseudoprogression, which we determined by using the histopathological analysis. So these are the images at the baseline, and these are the images at the follow-up. So as you can see, this is the tumor at the baseline, and then there's an increase in the tumor volume at follow-up time point. And also there is an increase in the vasogenic edema at the follow-up time point relative to baseline. But this is the case of pseudoprogression. So there is increase in the tumor volume, increase in the vasogenic edema, but this is a pseudoprogression. And this is the case of TP. As you can see, these are again the images at the baseline, and these are the images at the follow-up. And in this case, you can see there's a decrease in the volume of the contrast enhancement, and there's a decrease in the vasogenic edema. So there's a decrease in the volume, there's a decrease in the vasogenic edema, but still this is the case of the TP, which we determined by using the after looking at the pathological examination. So that's why the conventional MR imaging not reliable in determining the final diagnosis, whether the particular lesion is to progression or pseudo progression. And then there are other pitfalls associated with the RANO criteria. So first of all, they are highly subjective in nature, so they are non-specific. And what does the contrast enhancement show? Contrast enhancement basically shows a degree of impairment of blood-brain barrier. It does not give any information about the tumor biology or tumor microenvironment. So it just basically gives the how the blood-brain barrier is impaired. So, and this updated RANO criteria is also limited by the fact that if the size of the lesion is very, very small, especially if it is less than 10 millimeter in size, then this is very difficult to determine the tumor volume, or it's very difficult to determine the cross-sectional diameters. So in those cases, RANO criteria will not work. And again, if the tumor is irregular in shape and it has ill-defined margins, like as you can see, if it has ill-defined margin, then again, it's very difficult to determine the, looking at the, it's difficult to determine the margins of the tumor, and it's difficult to determine the cross-sectional diameter. And if the tumor is also cystic in nature, again, in this case, again, the updated RANO guidelines will not work. And in this particular case, as you can see here, this is the tumor with a large cystic cavity, and these are the leptomeningeal enhancement. If the leptomeningeal enhancement coincides with the margins of the tumor, then it's again, in those cases, again, it's very difficult to determine the boundary of the tumor. And it's in those cases also determined, it is very almost impossible to determine the cross-sectional diameter. And what happens when there is no enhancement? So some, like I think 10% of the GBM cases don't enhance at all. So in those cases, again, this updated RANO criteria will not work. So there are a large number of pitfalls or the limitations which are associated with the conventional neuroimaging. So now the question is, can we use metabolic or physiologic MR imaging to make the correct diagnosis, of TP and PSP? To answer that question, we have been using different imaging modalities, different advanced imaging modalities in last several years. And so today, basically, I'm going to show our initial experience and our past experiences of using metabolic and physiologic MR imaging in evaluating treatment response, not only to the established therapies, but also to the novel therapies. So what are these metabolic and physiologic MR images? So one of them is the diffusion tensor imaging. So what is diffusion? So diffusion is mainly the thermally induced random translation motion of the water molecules within a particular biological tissue. But as you know that biological tissues are highly complex in nature, so they so there's definitely impediment in the movement of the water molecule because of the presence of cell membranes or intercellular organelles or maybe viscous components. So the water molecules cannot move freely in the isotropic manner. So that's why in the biological tissue, the water movement is anisotropic, is highly anisotropic in nature. So the diffusion tensor imaging basically gives an idea about the white matter integrity. Let's say if you have an axonal fiber, this is, as you can see, this is the pen here, just like the axonal fiber. So water will flow freely along the longitudinal axis of this pen, or water will move freely along the longitudinal axis of the axons, but it will not freely move in the perpendicular direction. Okay, so this is called the anisotropic diffusion. So most of like in our neurons, axons, like the water moves freely along the longitudinal axis, but there's a definitely impediment in the movement of the water molecule in the perpendicular direction. So as a result of that, it basically gives information about the white matter structure or white matter integrity. And similarly, diffusion tensor imaging can also help us in understanding the cellular dimensions of the tumor. Okay, and then what are the perfusion weighted images? Perfusion weighted images, basically, in this case, we acquire the images, dynamic images before, during, and after the injection of the contrast agent. And then we get different metabolic maps. So this is one of the examples. So this is the cerebral blood volume. So essentially, perfusion imaging basically gives information about the tumor perfusion. So as we know that tumors, like basically they undergo a phenomena called angiogenesis. So there's a formation of new blood vessels, and all these new blood vessels are highly leaky in nature, tortuous, and they are dilated. So as a result of that, there's an increase in the blood volume or blood flow or both in case of the tumor, in most of the tumors. It does not happen in all the tumors, but in the most of the tumors, there's an increase in the blood volume, there's increase in the blood flow. So this dynamic susceptibility contrast perfusion imaging gives information about the blood volume or blood flow. And then there's another perfusion imaging technique called dynamic contrast enhanced MRI. So in this, again, we basically inject the contrast agent and we acquire the dynamic images before, during, and after the injection of the contrast agent. And one of the most important parameters which we can obtain using dynamic contrast enhanced MRI is K-trans. And the K-trans basically stands for the volume transfer constant, and it reflects blood flow and a combination of vascular permeability and vascular surface area. So as you know that in case of the blood, the tumors, there is increased vascular permeability, there's increased blood flow. So as a result of that, K-trans generally increases in brain tumors. Okay, and both CBV and K-trans are also putative marker of the angiogenesis. So whenever there is a angiogenesis, generally we see increased CBV and increased K-trans. And then there's another technique called proton MR spectroscopy. So this basically allows non-invasive assessment of metabolic alteration within a tissue of interest. So it basically, essentially, it gives information about the tumor metabolism. So as you can see, this is a brain image, and this is a single voxel in the left frontal lobe, especially the central semioval region. And this is the corresponding typical spectrum from this the normal brain. So this is actually a normal brain. As you can see, there are different peaks. So this is the largest peak. It corresponds to NAA, which stands for the N-acyl aspartate. And N-acyl aspartate is a marker of integrity and viability of neurons. And creatine is a marker of energy metabolism. And choline is a marker of cell density and cellular growth. And mannitol is a marker of basically osmolyte. It's an osmolyte, and it's a marker of gliosis. And this is the GLX basically stands for the combination of glutamate and glutamine. So as we know that glutamate is an excitatory amino acid, and glutamate is also involved in the cellular growth and cellular migration. And higher levels of glutamate have been observed in brain tumors and also in those regions which are associated with the seizure activity. So this is the basically particular spectrum of a normal brain. But in case of the tumor, as you can see, this is a single voxel again from the tumor, from the center of the tumor. So this is a typical pattern. This is a typical metabolic pattern of a GBM. So as you can see, there's a huge peak of choline. So in case of the GBM, there's a high cell density, high cellular growth. As a result of that, there's increased choline. And at the same time, there's a destruction of the neurons. So as a result of that, there's a decreased NAA. And there's a variable amount of lipid and lactate, which is a marker of anaerobic metabolism. And then, of course, there's an increase in the glutamate and glutamine. So this is a typical pattern of spectrum from the GBM or any brain or high-grade gliomas. So this is the multi-voxel. So this is the multi-voxel spectroscopy here. So as you can see, these are the two different voxels from the center of the tumor. And this is the voxel from the normal brain region. So multi-voxel, the advantage that we can assess the tumor heterogeneity. Like we can assess different voxels within or different regions within the tumor, and it can also help in determining the voxel from the normal brain region, just for comparison. So this is the advantage of the multi-voxel. But again, with the single voxel or single slice multi-voxels, there is some limitation. Sometimes like they don't cover the entire tumor volume, and they definitely don't cover the entire brain. So they are limited, they have a limited coverage of the tissue. On the other hand, whole brain spectroscopy is highly it gives information from the entire brain and from the entire tumor volume. And they are highly, they have high resolution. So that's why they also avoids the phenomenon of partial volume averages, which is also important, because when we look at a particular tissue, there might be some contribution from the contrast enhancing region or peritumor region or cystic cavities. So in those cases, the spectroscopy may be biased. But when we use high resolution spectroscopy techniques like whole brain spectroscopy, then we have the advantage that whatever the pixel or voxel we are looking at, it represents a particular pure tissue compartment, whether it is a contrast enhancing region or peritumor region or central necrotic component. So as you can see here, this is the post-contrast tumor-weighted image and overlaid 3D blob. This is a 3D blob of the contrast enhancing region. And this is the 3D blob of the colon to NNA abnormality. If you compare the size of this colon to NNA 3D blob and contrast enhancing region 3D blob, so the size of the colon to NNA 3D blob is approximately 4 times the volume of the 3D blob correspond to the contrast enhancement. So which indicates that the colon to NNA abnormality or the metabolic abnormality gives us true extent of the tumor abnormality. Like see the contrast enhancement, like it is limited, as you can see, like it has a smaller volume of the 3D. But here it is larger volume, so it is also covering those areas which cannot be assessed by using the conventional imaging. So this is the advantage of the metabolic imaging. We can see those lesions, or we can, that's what as I mentioned earlier, like these GVMs are highly infiltrative in nature. And those tumor infiltration, which we cannot see even on the conventional imaging or even on the histopathology. That's why we need some other techniques by which we can visualize those tumor infiltrative components. So colon to NNA or the metabolic abnormality is one of them by which we can determine the tumor infiltration with the better reliability, with more accuracy. Okay, so what we do basically, so we use all these metabolic and physiologic MR images, and we use different mathematical models to compute the parametric maps. And then we co-register all these modalities, all these parametric maps with respect to the anatomical images like post-contrast tumor-weighted image or T2 FLAIR images. And then we do the segmentation. We segment the contrast enhancing regions, which are the most solid or most malignant component of the tumors. So this particular example, as you can see, this is the post-contrast tumor-weighted image showing a ring enhancing lesion. And as you can see, this is a segmented ROI. There's a segmented region of interest, which correspond to this contrast enhancement. So we basically look at, as you can see, these two images are co-registered. So after co-registration, we use some mathematical tools, mathematical algorithm to segment this particular contrast enhancing region. And then we basically overlay this contrast enhancing or segmented ROIs on the parametric maps to determine the corresponding values. It may be diffusion tensor images derived parametric maps, or perfusion weighted images parametric maps, or maybe metabolic maps like colon to NNA maps, or maybe colon to creatine maps. Okay, so now what are the indication? Like how can we determine whether this particular parameter is showing positive response to the treatment or showing the negative response to the treatment? So these are the different parameters which we can obtain by using the diffusion tensor imaging, perfusion imaging, and spectroscopy imaging. So mean diffusivity and coefficient of spherical anisotropy like generally increases whenever there is a positive response to the treatment. On the other hand, fractional anisotropy, coefficient of linear and the planar anisotropy, cerebral blood volume, and colon to NNA ratio decreases whenever there is a positive response to the treatment. Okay, so this is a general idea. So basically, my purpose of showing this slide is just to make you aware that whenever there is an increase in the mean diffusivity or there is an increase in the coefficient of anisotropy, it means there is some positive response to the treatment. At the same time, whenever there is a decrease in the FA, CL, CP, CBV, or colon to NNA ratio, then there is a positive response to the treatment. So now this slide particularly shows one example of the two progression and this example of the pseudo progression. As you can see, these are the top row shows images of post-contrast tumor-weighted, T2 FLAIR, mean diffusivity, and fractional anisotropy. At the bottom row is showing images corresponding to coefficient of linear anisotropy, coefficient of planar anisotropy, coefficient of spherical anisotropy, and cerebral blood volume. So as you can see here, this is the case of the tumor progression. So this is a contrast enhancing tumor in the left parietal lobe, and this is the corresponding T2 flare. And by the way, all these images are co-registered. So as you can see, they're all co-register resized. And so that's why like this is very important when we basically look at the different when we compute or measure the different imaging parameters. So this is an important step. So this is the tumor, as you can see, in the left parietal lobe, contrast enhancing tumor. This is the contrast enhanced T2 flare, and this is the MD map. And as you can see in the CBV, you can see very high CBV corresponding to the contrast enhancement. This is the contrast enhancement, and this is the CBV. As you can see, there's a high CBV. This is in case of the 2 progression. And this is the case of the pseudo progression. Again, you can see here, this is a tumor in the right parietal lobe. This is a contrast enhancing rim, and this is a central necrotic core. And if you look at the CBV here, CBV is less. If you compare the CBV in case of the TP compared to PSP, CBV is higher in the TP case compared to the PSP case. So this is the summary of our findings. Like we recruited approximately 45 cases in this particular study, and these are the box whisker plots. So as you can see, in case of the TP, there's an increased relative cerebral blood volume compared to the PSP. There's significantly higher RCBV in TP cases compared to the PSP cases or mixed tumors. Okay, in this particular, this is the gold study. Like this is a gold standard study in the sense that all these patients had, we selected only those patients who underwent repeat surgery. So in all these cases, we had the tumor specimen to determine the final diagnosis of TP and PSP. So in this particular study, when the malignant features were more than 75%, then we considered those cases as TP. When the malignant features were less than 25%, we considered those cases as PSP. And when the malignant features were in the range of 25 to 75%, we consider those lesions as mixed tumors. So this is the advantage. I mean, like in this particular study, we, as I mentioned, we recruited only those patients who had the repeat study, and we had the tumor specimen to make the final diagnosis. So there's no bias involved in this particular study. So in case of the TP, we observed significantly higher RCBV compared to the PSP and the mixed tumors. Similarly, we observed significantly higher FA in TP compared to the cases with PSP or mixed tumor. And at the same time, we also observed significantly higher CL compared to the mixed tumors and the PSP. On the other hand, if you look at the MD was higher in the PSP, lower in the TP and the mixed tumor, but it was not statistically significant. And as I mentioned earlier, increase in MD means better treatment response. Increase in CBV means worse treatment response. So as you can see, in case of the TP, like there is a higher CBV, higher FA in case of TP, and higher CL in case of TP, but higher MD in case of PSP, but it is not statistically significant. Similarly, there is a higher CS in case of the PSP, but again, it is not statistically significantly different. So when we did the different statistical analysis, especially the multivariate logistic regression analysis, then we came up with a particular classification model or the predictive model. And this model particularly selected 3 main parameters. And these parameters are fractional anisotropy, coefficient of linear anisotropy, and maximum value of the relative cerebral blood volume. So when we use this model to differentiate TP from PSP, we observed a sensitivity of approximately 76%, specificity of 95%, and accuracy of 90% in distinguishing TP and PSP. So this model is relatively highly accurate in differentiating TP and PSP. So when we use whole brain spectroscopy to differentiate TP and PSP, we observed higher choline to NNA ratio in case of the TP compared to PSP. As you can see, this is a red mark. So we got higher choline to NNA ratio in case of the TP compared to case of PSP. So again, this is another example. Like as you can see here, these are the 3D blobs again. So if you look at the T2 flare, and this is the case of the 2 progression, this is the case of the pseudo progression. And as you can see here, the 3D volumes of the flare abnormality is approximately similar. So the flare is not reliable in differentiating TP and PSP. But if you look at the volume of the 3D blobs of the choline to NNA abnormality, you can see the size of the 3D blob in case of the TP is definitely higher compared to the size of the 3D blob in case of the pseudoprogression. So this again emphasizes the importance of the whole brain spectroscopy in differentiating TP and PSP. So when we combine the different data together, and these are the box Whisker plots again, so we observed significantly higher colon to NNA ratio in TP from contrast enhancing region, from the immediate peritumor region, and from the distal peritumor region. Like even from the contrast enhancing region and the peritumor region, there were higher contents of colon to NNA ratio in TP compared to PSP. Similarly, we also observed significantly higher colon to creatine ratio from contrast enhancing region in TP compared to PSP. Although we had trends of higher colon to creatine ratio and colon to creatine ratio from the IPR, immediate peritumor region, and distal peritumor region in TP compared to PSP, but they were not statistically significant. So when we did the logistic regression analysis to determine the model, so we observed that when colon to NNA ratio from all the regions, means all from the solid contrast enhancement region or from the peritumor regions, and when we combine the colon to creatine ratio only from the contrast enhancing region, then we observed an accuracy of 86%, sensitivity of 84%, and specificity of 80% in distinguishing TP from PSP. So this is a summary of the part 1. So the number 1 point is the conversion MR imaging may be limited in determining the final diagnosis of TP and PSP, but the metabolic and the physiologic MR imaging may be more sensitive and hence may be more reliable and useful in distinguishing TP from PSP. However, single imaging technique or the single parameter may not be enough. That's why basically our aim is to exploit the unique strengths of different imaging modalities together, because they provide complementary information. So if you do the multi-parametric data, if you use the multi-parametric approach to analyze the data, then that may give us better information, more reliable information, and more accurate information in distinguishing the TP from PSP, and in the sense in evaluation of the treatment response in this patient. However, there's a pressing need for the development of novel therapy, because as we see that even after the treatment of the conventional, after the surgery and the concurrent chemoradiation therapy, the overall survival of the patient is approximately 14 to 16 months. So that's why there's a pressing need for the development of novel therapies which can further improve the survival outcomes and the quality of life of this patient. So there are like many recent technical advancements that have improved our understanding of the molecular biology of the GBMs. And we can better characterize microenvironments of the brain and the tumor, and we can also better recognize immune system interaction and the host factors. And all this like information can help us in designing and devising new treatment modalities. So what are the different emerging therapeutic interventions which are available these days to treat glioblastomas? So one of them is the extended resection. So in terms of like the complete resection of the tumor sometimes may not be possible, especially if the tumor is located in some allocant location, like the location which are very, very like important for the normal function. Or sometimes they may be located in the regions which are not amenable to the surgery, like if they are present in the deep brain region, like posterior fossa, or sometimes the thalamus. In those regions, we cannot remove the tumor as much as possible. But if possible, like if we can extend, like it has been shown that the survival outcome is directly proportional to the extent of resection. If there's a more extent of resection, better the treatment outcome, better the clinical outcome. And the second modality to improve the survival outcome or maybe quality of life is to intensify the concurrent chemoradiation therapy. And then there are certain therapies are available which target different factors. So one of them is tumor growth factor receptors or downstream pathways or angiogenesis, or there are certain therapies which target modulation of cancer stem cells or cell cycle regulations. And then there are some new therapies available. These are called electric field therapies and the immunotherapy. There are large version of immunotherapies available these days, but all of them are in the experimental stage. But the electric field therapy, which is also called tumor treating field, is FDA approved. It is the only therapy after surgery, chemoradiation, which has received FDA approval for the treatment of newly diagnosed tumors as well as recurrent tumors. But the success of this emerging therapies depend upon two important factors. Number one, the careful selection of the patient based on the genetic mutation and the protein expression profile, which are unique to a particular tumor, and early evaluation of the treatment response using reliable, reproducible, and accurate imaging biomarkers. So now I will briefly talk about what are the elective field therapy, what are the tumor treating field. So the tumor treating field basically involves the oscillating electric field, which are tuned at a particular frequency and a particular intensity. The frequency approximately 200 kilohertz for gliomas, and the intensity is around 1 to 3 volt per centimeter. And these tumor treating fields are delivered by means of two pairs of transducer arrays. As you can see here, these are two pairs of transducer arrays, which are placed on the shaped skull close to the tumor. So these like transducer arrays, like one pair is positioned in the right-left direction, and one pair is positioned in the anterior posterior direction. And these are the different batteries which are used to charge the transducer arrays. So this is one particular example of the transducer arrays here. So they are basically like worn in the form of a big band aid. They are just like the big band aid. And each transducer array consists of 9 biocompatible ceramic discs, which are used to deliver the electric field at a particular intensity and frequency. So what is the action mechanism? So briefly, I will talk about how the tumor treating field works. So just by going to the basic physics, this is like a high school physics. As you can see here, this is a paraplate capacitor with a positive charge and a negative charge. And this is the negative charge. So obviously, like a negative charge will move towards the positive charge. So this is the simple phenomenon of electrophoresis. And this happens whenever there is a uniform electric field. But whenever in the situation whenever there is a non-uniform electric field, then if you have a polar molecules, they move towards that end of the capacitor where the electric field is converging, where the electric field intensity is more. So this is the as you can see here, the electric field is converging in this area. So the polar molecule is moving in this particular direction. So this is called dielectrophoresis. So with this background, what is happening at the cellular level? So as you know that the cell division consists of interphase and the mitotic phase, and the mitotic phase is further divided into prophase, metaphase, anaphase, and telophase, followed by cytokinesis. So tumor treating field mainly works in the metaphase stage or the late telophase and the cytokinetic phase. It is basically anti-mitotic therapy. So what does it do? So like in case of cell division, there are two main protein molecules which are involved. One of them is the tubulin, and other is septin, and both of them are highly polar molecules. So as a result, when these tumor treating fields are applied, so these tumor treating field prevents the polymerization of tubular molecules or the septin molecules. So as a result of that, there is no complete formation of the spindle apparatus. So as we know that in the metaphase stage, two sister chromatids segregate and then they move to other two poles of the cells. But in this particular case, whenever there is an incomplete formation of the mitotic spindle as a result of unpolymerization of the tumor tubulin subunits, so the sister chromatids are not equally distributed in the two daughter cells. So as a result of that, from the one parent cell, we get two daughter cells, but those two daughter cells have unequal number of chromosomes. So similarly, the septin has a role in the cytokinesis. So whenever as a result of this impairment, what happens? One parent cell divides into two daughter cells, but these two daughter cells are of unequal size. So nutshell, like as a result of the tumor treating field, one parent cell give rise to two daughter cells. They are of unequal size and they have unequal number of chromosomes. So those cells undergo apoptosis and then eventually they die. So this is so that's why this tumor treating field basically inhibits the cell growth. And the advantage with the tumor treating field is that it mainly inhibits the rapidly dividing tumor cells. It does not affect the normal brain. So this is it has very high safety profile. It has there are no toxicity associated with the tumor treating field. The only side effects associated with the tumor treating field is the skin irritation, which happens beneath the transducer arrays. But these skin irritations are also of mild to moderate in nature, and they don't happen in all the patients. It has been reported that they happen only in 40 to 50% of cases. And it can also be treated by applying steroids or maybe by ointment. So in essentially, like Tumor Treating Field has essentially no side effect. It has very good safety profile. So this is the advantage, unlike chemo radiation therapy, which are associated with a lot of side effects. The Tumor Treating Field is completely safe in nature. So now basically I will show some slides just to demonstrate the preclinical findings in terms of how the Tumor Treating Field works and what are the different factors on which the Tumor Treating Field depends. So these are the different cancer cell lines. As you can see here, the 4 patient cancer cell lines, and there are the 7 animal cancer cell lines. And this TER stands for therapeutic enhancement ratio for cancer cell lines. So, and the TER defined as growth rate of control cells minus growth rate of Tumor Treating Field treated cells divided by growth rate of control cells. So whenever there is a therapeutic enhancement ratio is greater than 0, it means the Tumor Treating Field is doing something. It is doing some, it is providing some positive response. As you can see in all the cancer cell lines, when they were exposed to Tumor Treating Field tuned at 100 kilohertz and intensity in the range of 1 to 1.4 volt per centimeter, the TER is greater than 0 in all the cases. It means although there is a variable response to the treatment, but all cancer cell lines are showing some kind of treatment. So this is the positive outcome of this particular slide. So irrespective of the cancer cell line, whenever those cell lines are exposed to the Tumor Treating Field tuned at a particular frequency and intensity, they show some positive treatment to the therapy. So now what is the relationship between the orientation of the Tumor Treating Field and the axis of the cell division? So as you can see here, so this dark bar, bar basically indicates the damaged cells, and this white bar indicates number of live cells. So as you can see, when the angle between the orientation of the TTF field and the axis of cell division is 0 degree, means when they are parallel to each other, we have the maximum number of damaged cells. As you can see, the ratio between the alive cells and the damaged cells approximately, I think 1:4 to 5 ratio, right? And if we go into the different cell divisions like metaphase, anaphase, or telophase, so you can see here at the metaphase stage, this is again this dark bar correspond to the number of damaged cells, and this white bar correspond to the number of the live cells. And if you compare these two bars, they're approximately ratio of 1:8. So they are like, especially in case of the metaphase, when the orientation of the TTF field and the axis of cell division is 0 degree, means they are parallel to each other. And even at the metaphase stage, so this TTF field has the maximum effect. Okay, and the therapeutic effect of the TTF field is also field intensity dependent. So as we keep on increasing the field intensity, the effect, the therapeutic effect and the cytotoxic effect of the TTF field increases. And the electric field intensity, which is induced by this TTF field within the brain, actually is non-uniform. It depends on the tumor location, it depends on the size of the tumor, it depends on the dielectric properties of the brain and the tumor, and also depends on the layout of transducer arrays, how we place those transducer arrays, how proximal those transducer arrays are to the different regions of the tumor. So all these factors basically determines the field intensity. But as we keep on increasing the field intensity, the therapeutic effect of the TTF field essentially increases. Similarly, the therapeutic effect of the TTF field is also time dependent. So more the exposure time, more the cytotoxic effect, or more the therapeutic effects of the TTF field. So that's why, like in case of the patient, we generally advise patient to wear these transducer arrays for approximately 18 hours per day. So better the compliance rate, better the therapeutic effect, better the cytotoxic effects of the tumor treating field. So it has also been observed that there is a synergistic effect of the tumor treating field with the chemotherapeutic agents. As you can see here, this is the this is the diagram which shows effect of tumor treating field alone, and this is the effect of the tumor treating field in combination of chemotherapy, like in case of the cyclophosphamide. So as you can see here, as we keep on increasing the concentration of the chemotherapy, or like the effect of the tumor treating field is better. So they act in a synergistic manner. That's why clinically whenever patients are treated with TT field, they are also advised to take temozolomide as a chemotherapeutic agent. So they work in synergistic manner. That's why and we expect that the combination of TT field and the chemotherapeutic agents will give you maximum survival benefit and maximum quality to life of the patient. So there are large number of multicentric clinical trials, which are phase 3 clinical trials. They have shown that patients treated with the tumor treating field and temozolomide are associated with the significantly prolonged progression-free survival as well as overall survival compared to the patient who were treated with temozolomide alone. So as you can see here in those particular trials, like progression-free survival was prolonged by 3 months and the overall survival was prolonged by 5 months. And as I mentioned earlier, like there was no toxicity involved in, no toxicity was observed in those particular patients. Only 40 to 50% of those patients experienced mild to moderate skin irritation, which can easily be treated by applying steroids or ointments. Okay, so this is our experience. So as you can see, this is a particular patient, GBM patient, who was treated with the tumor treating field plus temozolomide. So this is the images at the baseline, and this is the first follow-up at 1 month, and this is the second follow-up at 2 months. So as you can see here, there is a slight decrease in the tumor size. So this is the tumor at the baseline, and then there's a slight decrease in the tumor size. And these are the advanced imaging. Like again, we when we scan this patient, we acquire diffusion imaging, perfusion imaging, and spectroscopy. And as you can see, these are the co-registered MD, FA, and CBB map. This is the baseline and this 2 month follow-up period. As you can see, there's a slight decrease in the CBB compared to the baseline. So this is the whole brain spectroscopy. So as you can clearly see that this is the this correlating to NNA abnormality at the baseline, and this is correlating to NNA abnormality at the second follow-up period. So as you can see, the volume of this correlating to NNA abnormality at 3D at second follow-up period is less than compared to the baseline time point. So which indicates some positive response to the treatment. So these are actually the trends. These are the trends in the percentage change in the different parameters like FD, FA, CBV maximum, correlative to NNA ratio, and tumor volume at 1 and 2 month follow-up time point relative to baseline. So as you can see, there's an increase in the MD, there's percentage increase, there's progressive increase in the percentage in the MD, there's a progressive decrease in the RCBV, there's a progressive decrease in the tumor volume, there's a progressive decrease in the correlative to NNA, and then there's a progressive decrease in the percentage change in the FA, which all these parameters indicate that there's some kind of positive response in this particular patient when this patient received the combination of tumor treating field and TMG. So, so this is basically another case. As you can see in this patient was followed until 3 months, and again, as you can see here, there is a progressive percentage increase in the MD at different follow-up period compared to the baseline, and then there is a decrease in the choline up to 2 months, and then there was slight increase in the correlative to NNA ratio at third follow-up period, where there is a continuous decrease in the FA value. And at the same time, if you look at the RCBV, there is a slight decrease and then almost stabilized. So this patient also showed positive response to the treatment. So when we did the survival analysis from we have already recruited 18 patients in our study. So when we compare the median overall survival of patients who were treated with TMG plus TTF field compared to the patient who were treated with standard of care treatment, we observed significantly prolonged overall survival in patients who were treated with tumor treating field and TMG. And as you can see, the median overall survival for the patient who were treated with standard of care was approximately 14 months. And the median overall survival for the patient who were treated with tumor treating field and the TMG was approximately 18 months. So the 4-month survival benefit in the cohort of patients who were treated with the tumor treating field and TMG compared to the patient who were treated only with the standard of care. So this is a very good study actually. So this is basically the purpose of this particular slide is to show, to provide the quantitative evidence of the safety profile of the tumor treating field on the normal brain. So as I mentioned earlier, like the tumor treating field has very high safety profile. So there is no toxicity involved in the tumor treating field, but the purpose of our study was to determine whether there is some harmful effect of the tumor treating field on the normal brain. Because we know that because as a result of the radiation therapy, there are like several people, including from our group, have demonstrated there's some damage to the normal brain region when they were exposed to the radiation, different doses of the radiation. So our purpose in this particular study was to use diffusion imaging to determine whether there is some damage to the normal brain or there is no damage to the normal brain. So when we compared the MD value and the FA value between the baseline time point and the 2-month follow-up period from different normal gray matter regions and different normal white matter regions, we did not observe any significant difference in either of the MD values or FA values, which suggests that there was no damage to the normal brain region when those patients were exposed to the tumor treating field. Okay, so with this now, now I'm going into the immunotherapies. So these days, like there are large number of immunotherapies available, but they are all under the experimental conditions or experimental routine. So one of them is a vaccine. Like we have been working on the DC vaccine, which is called dendritic cell vaccine. There are cell-based therapies. There are some checkpoint inhibitors like PD-L1, PD-1, or CTLA4 checkpoint inhibitors. Or there are some oncolytic viruses, like they have been used to treat the glioblastomas. Just for the sake of interest of time, I am basically today just concentrating only on the cell-based therapies. And cell-based therapies, basically, I will mainly talk about chimeric antigen T cell receptors. So in our study, like we recruited 10 patients with the recurrent GBMs, and we have already demonstrated the synthesis, delivery, and infusion of the CAR-T cells in 10 recurrent patients who were MGMT unmethylated, who were IDH wild type, and who were EGFRV3 positive. So these are all different genetic markers which indicate all these tumors were highly aggressive in nature. The MGMT unmethylation, IDH wild type, EGFRV3, they all indicates, they all like suggest that GBMs were highly aggressive in nature. So in this particular study, we recruited only 10 patients, and we successfully demonstrated the safety profile, the synthesis, and the formation of the genetically engineered T cells. So how does this work? So in this particular case, what we do, we basically take the sample from the blood sample from the patient, and then the T cells are extracted from this blood sample. And then these T cells are transduced to express chimeric antigen receptors. And these receptors are targeted to different antigens or different epitopes of the antigens. Like in this particular case, we used EGFRV3 epitope, which is expressed in approximately 30% of the patient with GBMs. But different people have been using different epitopes like CD19 or CTLA4. So they are the different like or interleukin 13. So they are the different epitopes which are available these days to target these CAR-T cells. So in this, but in our particular case, we used EGFRV3 as an epitope to target CAR cells. So when we and then after the genetically modification, we basically allow these cells to grow, and then we infuse these CAR-T cells to a particular patient. So this is particular example. As you can see, these are the different images again. Like this is a post-contrast imaging image, mean diffusivity, fractional isotropy, CBV, and calling to NNA map. These are the images at the baseline, and these are the different images at the different follow-up period. So as you can see here, in this particular patient, like as you can see, like we have mixed response. So there's in some patient, like we saw increase in MD or decrease in MD. So each particular parameter, as I mentioned, like each individual parameter may not be reliable to determine the to determine the treatment outcome. So we have to combine all these parameters together to determine the final diagnosis. So one way of combining this parameter, as I mentioned earlier, is to develop some kind of a predictive model or classification model. Like in our previous case, we used combination of FA, fraction anisotropy, coefficient of linear anisotropy, and maximum value of the relative cerebral blood volume, so RCVB maximum. So when we combine these three parameters together, we come up with a parameter called probability of tumor progression, which is also called PP value. So when the predictive PP value were more than 50%, we consider those tumor as TP or to progression. When this PP value was less than or equal to 50%, then we consider those values as PSP or pseudo progression. So our aim in this particular study was to use those PP values to categorize each lesion at each time point, each follow time point, to see whether that particular lesion is TP or PSP. So in this particular patient, like we recruited 10 patients, as I mentioned, and of this 10 patients, 3 patients died within 6 months after the infusion of the CAR-T therapy, and 7 patients lived longer than 6 months. And the overall survival from this 10 patients was approximately 9.2 months. And these are, by the way, these are the recurrent tumors. These are not the newly diagnosed tumors. So, and the overall survival, the median overall survival in case of the recurrent tumors is approximately 6 to 9 years. So in this particular study, we observed that the overall survival from the start of the infusion of the CAR-T therapy until the point of death, it was approximately 9.2 months. So, so out of this 10 patients, 4 patients did not undergo any surgery, and 6 patients undergo surgery at different time points. And of this 6 patients, we had 8 different lesions. So this particular slide shows 8 different lesions, and these are the different follow-up time point. And we used PP value to determine the final diagnosis. And all these patients, as I mentioned, they underwent surgery. So we have the tumor specimen to make the final diagnosis. Right? So our aim was to test whether the PP value is correct, like it can predict, like what is the probability that a particular lesion or particular PP value will help us in determining the final diagnosis, whether it is TP or PSP. So as you can see here, these are the lesions, like lesion number 4, lesion number 5, lesion number 8, or lesion number 6. To begin with, they have low PP values. So as I mentioned earlier, if the PP value is less than 50%, those cases were considered as PSP. If the PP value is more than 50%, those lesions was considered as TP. So in these 4 lesions, like lesion number 6, 8, 4, and 5, as you can see, to begin with, PP value is close to 0. Okay, so they were considered as PSP. But as the treatment progresses, they slightly increase in the PP values, but they're all less than 50%. So although there's a slight increase, there's a steady increase, or sometimes there's a decrease in the PP value, but final diagnosis from this specimen was PSP, which we confirmed by the histopathological analysis. And our PP model also predicted pseudoprogression. So those 4 lesions had low PP value at all time points, and all those 4 lesions turned out to be pseudoprogression on histopathology, which confirms the validity of the PP values. And as you can see here, there are the 2 lesions. So lesion number 7, as you can see here, or lesion number 2. So to begin with, these lesions had very high PP value. Okay, and then they showed decrease. But although there was steady decrease, but they still remain more than 50%. So they were considered as TP. And and on histopathology, this lesion was also turned out to be TP. And this particular lesion here, to begin with, this particular lesion has very high PP value, and it stayed same at one follow-up time point. So, and this lesion was also turned out to be TP. And this particular lesion, lesion number 3, we did not have any baseline imaging findings because of the poor data. But this patient had, at second and third follow-up time point, it has high PP value. And when we had the tumor specimen after the surgery, repeat surgery, that tumor specimen turned out to be TP. So which again, validate our finding that PP value is a reliable parameter to determine the treatment response. Okay, so in summary, when we use in combination the metabolic and physiologic MR imaging parameters, they may be valuable in evaluating treatment response in GBM with high accuracy. However, further progress requires standardization of these imaging protocols and conduction of large multi-centric validation studies for the clinical translation of advanced imaging techniques into routine clinical practice. And to acknowledge, this is Dr. Lavner. She is my section chief in the neuroradiology department at Penn. This is Dr. Stephen Brem, who is a neurosurgeon, well-famous neurosurgeon. This is Dr. Mohan. He's a neuroradiologist, and he has recently, actually 4 years back, he got one grant from the Novacure, which is a company which basically developed the tumor treating field. So I'm working closely with him. This is Dr. Poptani, who is my supervisor, previous supervisor. And this is Dr. Maclean Nasrallah. She is a neuropathologist who has helped us emotionally. And this is Dr. Wang, Dr. Stephen Bagley, who is a neuro-oncologist. And Lisa and Lauren, they also help us in designing study, in conduction study, and in the data analysis. So thank you very much. So now I'm open for any questions.
Oh, thank you very much. That was very informative. We have a few questions. I know we're running a little late, but first question is, could these techniques be done at any institution or only at special institutions?
No, I think these techniques can be done at any institution, as long as we have, especially these days, actually, most of the institutions, especially in the US or in the developing countries, we use 3 Tesla MR images. So, and they are the standard techniques, like the diffusion imaging and perfusion imaging are standard techniques. But spectroscopy, we can do single voxel spectroscopy, multi-voxel spectroscopy at all centers. But the whole brain spectroscopy is not available at all centers. It is actually it is actually an experimental sequence. So it has been devised by Dr. Andrew Mosley from University of Miami, and we have been working with him since now 10 years. But as I mentioned, but the diffusion imaging, perfusion imaging, and single voxel and multi-voxel spectroscopy, it can be done at any scanner of any vendor. Maybe it may be Siemens scanner, Philips scanner, or Toshiba scanner, or whatever, or GE scanner, and it can be done at any institution throughout the world.
Okay, why wouldn't these things be done as a standard? Because most of our patients are not getting this.
Yeah, I mean, these days, actually, at our institution at Penn, all patients with brain tumor, they receive anatomical images, they receive diffusion imaging and perfusion imaging. And in some cases, especially the newly diagnosed tumors, we also require spectroscopy. The important thing is how we analyze the data. So there are some commercially available tools, technicians can use those tools to determine the CBV values. They can determine the different diffusion tensor derived parameters, but they don't do some rigorous analysis. They don't register data, they don't register images, they don't do any kind of reslicing, or they don't do any kind of segmentation. So although they use advanced imaging, but those advanced imaging parameters may be reliable or may not be reliable, depending upon the how we process that particular data. So of course, as I mentioned, in our institution at Penn, all those patients with GBMs, they undergo advanced imaging, metabolic and physiologic imaging. But the manner which we use different tools to analyze the data, it may be different from different centers.
Okay, do most insurances pay for spectroscopy?
Yes, spectroscopy is very important, especially the acquisition, because spectroscopy is very, very sensitive to visual inhomogeneity. As you know, these high-grade tumors are very prone to susceptibility artifacts can lead to macrohemorrhages. So when we acquire the spectra, it's very, very important to localize the voxel. Or because if we are including some hemorrhagic area within the voxel, then the shimming will not be good. As a result of that, water suppression will not be good. And in the nutshell, spectra will be screwed up. So to analyze the spectroscopy is very easy. We can clearly see, even on the scanner, we can see different metabolites. We can see whether it is NNA, it is decreased, or choline is increased. So interpretation of the MR spectroscopy data is relatively easier compared to diffusion and perfusion images, but the data acquisition is very, very important. We have to be very, very careful in selection of the voxels, and the important step is shimming, how well we shim the magnet. Like our aim is to homogenize the main magnetic field. If we are successful in doing the shimming, then we are successful in the water separation, and we will get very good spectrum.
Okay. Somebody asked, for this to be useful, obviously, it has to be done serially. Does it have to be done on the same scanner, or can you do it from different scanners?
Like ideally, it should be on the same scanner using same like techniques and same parameters. But there's some parameter like detailed drive parameter like MD values, FA values. Although there are different studies, like different studies have shown that if you change the parameter, like if you change repetition time, echo time, or resolution, or SNR, because as the details also highly SNR dependent. Like if you use grappa more than 3, extraction factor 3, then we get very low SNR. And if you keep on increasing the B value, although sensitivity of the diffusion weighted increases, SNR decreases. So I would recommend to use the same technique, same parameter, and essentially on the same scanner. So especially for a particular patient, if you do the serial scanning. But nevertheless, like I would say, if the patient is being scanned on different scanners with approximately similar parameters, I think in those clinical settings, we can use the serial MR imaging parameters to evaluate the treatment response. But ideally, it will be better to use the same scanner, same technique, and the same imaging parameter for a particular patient.
Okay. Before you mentioned that when you compare pseudoprogression to real progression, there's a higher survival with the pseudoprogression. Right?
Yes. Yes.
How would that compare to somebody with no progression on scan? Does pseudoprogression have a better benefit or less benefit than no progression?
Pseudoprogression is, as I mentioned, like so. See, like as you know, GBMs are highly heterogeneous and they are highly aggressive.
Right.
So at a particular time period, we may get pseudoprogression, but eventually, down the line, these patients, all those patients undergo tumor recurrence and they progress at later time points. That's why they die within 2 years. But at a particular time point, to determine whether it is a pseudoprogression or not a pseudoprogression, because determining the correct status will help us in determining the further course of action, whether that patient may undergo repeat surgery or the patient may be recruited for some other alternative clinical trial, like like the tumor therapy, or maybe tumor treating field, or maybe immunotherapy, or maybe Avastin. So yes, like pseudoprogression is like to determination of TP versus PSP is important, and definitely pseudoprogression patient have better survival, and they respond better to the TMG. But eventually, all those lesions progress to the TP at one particular time point later, like later in the during the course of their disease.
Okay, you were talking about the survival benefit of tumor treating fields.
Yes.
Do you remember what the average compliance was in your study?
Okay, so in the clinical trials, like they have reported approximately 70 to 75% compliance rate, but in our study, like we have observed approximately 80% of compliance rate.
Okay. I think this might be the last question that I see so far. This person has a DIPG. Can this be used in the ponds?
The tumor treating field?
No. I'm sorry. This is a separate question. They want to know if a drug is working early with kid with DIPG. So which modality would you use to see if a DIPG drug is working or not?
Okay, I think I would again recommend to use multi-parametric approach. Definitely.
But the same stuff will work.
Yeah, because we have to exploit the unique strength of different techniques together to make the final diagnosis, because they are complementary to nature, and sometimes one techniques may not help, or sometimes one technique, like let's say if we scan a particular patient at a particular time point, because of some reason or the other, we may not get one reliable data, or the data may be corrupted. So that's why it is always better to acquire more than one modalities. To, if something goes wrong with one particular technique, then we have the backup technique to make the final diagnosis. But ideally, it will be definitely better to combine different modalities together and different parameters together to make the final diagnosis, which will give us more reliable and accurate information.
Okay, actually, one more last question. It's a little bit off topic, but it involves MRIs. Is there any way to tell using an MRI if a patient has certain biomarkers such as like H3K27M?
Like, to my knowledge, I have no idea about this.
Okay.
Like, we have been working on different genotypes, like especially the IDH mutant. Like we can determine whether the particular glioma is IDH mutant or IDH wild type, mainly by looking at the 2-hydroxyglutarate. Or like in the past, we have also used different imaging modalities to differentiate, in case of oligodendrogliomas, 1p19q deletion, 1p19q intact. But in this particular case, I have no idea.
Okay. That's about all for us. We don't have any more webinar scheduled, but if I do, I'll announce it in our news blast. Thank you very much. And
Thank you very much.
good night to everybody. It was interesting. Bye-bye.
Thank you very much.